So good morning, good afternoon, good evening. Welcome to our Global Network webinars. Today we are happy to have with us Burgess, Mwenya Kasonde from the World Health Organization and Hellen Kiarie from the Ministry of Health in Kenya, who will present to us on the Health Data Collaborative. The Health Data Collaborative has three objectives: to strengthen country health information systems, to align partner resources with countries' data and digital priorities, and to adapt global data and digital tools with country and local contexts. The Health Data Collaborative was launched in 2016, following a high-level summit on measurement and accountability for results in health. The Health Data Collaborative currently supports 11 countries and is represented in 7 constituencies. The Secretariat of the Health Data Collaborative is hosted by the World Health Organization with staff from the WHO and UNICEF, and helps convene and facilitate dialogue between various UN agencies and partner initiatives to provide support at country, regional, and global levels. The HDC plays a knowledge broker role, helping to disseminate information and best practices from different data and digital initiatives, including specific webinar sessions. During our Global Network webinar today, our speakers will give an update of the Health Data Collaborative will provide country perspectives on the Health Data Collaborative and will outline the added value of the Health Data Collaborative and opportunities for alignment towards common sustainable development goals. So let me now introduce our speakers. We have with us today Burgess, who is a development cooperation specialist and unit head for data coordination, governance, and partnership in the division of data analytics and delivery for impact at the WHO. Over the last 25 years, he has worked on a broad range of public health issues that rely on data for planning, financing, and policymaking for a large number of organizations within and outside of the UN system. Mwenya Kasonde is a global health consultant currently in the coordination, government, and partnership team of the WHO. She's supporting the Health Data Collaborative Secretariat, country work, working groups, and various aspects of governance. Before joining the World Health Organization, Mwenya was Assistant Director for Global Health in Zambia's Ministry of Health. She holds degrees from the Royal College of Surgeons of Ireland and the University College of Dublin. Hellen Kiarie is the head of the Division of Monitoring and Evaluation at the Ministry of Health in Kenya. She's a health system expert who has a wide experience in implementing readiness assessments in health facilities, including communities. She led the implementation of the 2018 Health Facilities Assessment in Kenya, as well as 2 COVID-19 readiness assessments. Hellen serves as a co-chair of the Health Data Collaborative, where she represents Kenya. And now I just want to point out a couple of practical things. So we will, after the introduction, first hear all presentations, and we'll then have the Q&A session at the end. During the presentation, please feel free to write your questions into the meeting chat at any time. During the Q&A session, we can either ask the question for you, or you can raise your hand in Teams and ask the question yourself. As always, this Global Network webinar is being recorded and will be made available on the Global Network of Data Officers and Statisticians at yammer.com/UNstats. We invite you to continue the discussions on the Global Network after the webinar. And now I would like to hand over to Greg. Greg, the floor is yours. Thanks.
Great. Thank you very much, Alex, and thank you very much, colleagues, for inviting us to help present on the Health Data Collaborative. And myself and Mwenya, just for clarity, we play a secretariat role for the Health Data Collaborative. And as you'll come to learn, it involves many different entities and agencies. So Mwenya and I are really the secretariat. We had hoped that our colleague Hellen, who's in the Ministry of Health from Kenya, would be able to say some opening remarks, but we understand she's busy just now and might be with us later. So what we'd like to do, Mwenya and I would like to do two things in the next sort of 20-30 minutes. One is to just deliver a short video, which will give you a more interactive way of describing the Health Data Collaborative. It lasts for about 3.5-4 minutes. And then Mwenya and I together will present a few slides and then finish off with any questions you want to ask. And feel free to ask any questions in the chat, as Alex has said, and we'll facilitate afterwards. So Mwenya, do you mind just showing the video to start off with? Thank you.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems, 2. Aligning partner support for country priorities, and 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1. Aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2. Access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3. Technical and financial resources that can be invested more efficiently because they are centred around common goals. And 4. Decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many, many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
Thank you, Mwenya, and thanks for those that were watching. So we're just going to get some slides up and give you a bit more background. We hope that you enjoyed that video, which we feel kind of dilutes basically the voices of myself and Mwenya and gives you more perspective, and it's got a few colleagues in the video too. Unfortunately, Helen still isn't able to join us, so I think we'll just, sorry, Helen has joined us. Great. So I'm just wondering whether Helen, our colleague from the Ministry of Health in Kenya, might want to make some opening remarks as a co-chair of the Health Data Collaborative. Helen, if you're able to, do you want to make a few remarks? Thank you.
Usually we're already able to make her presenter. Okay, good. Helen, you can go ahead. We see you, Helen, a little bit blurry, but we can see something. Now we see.
Oh,
can you
sorry.
try to put the camera on yourself? Yeah, thanks so much.
Sorry, it's a bit blurry. Can you hear me?
Yeah, we can hear you. So
sorry,
just
I
go
didn't
ahead.
realize there's a change of timeline. I was thinking you're 1 hour away. I think sorry about that.
No problem.
Yes. Thank you, everybody. And sorry again for joining late. I just want to really emphasize the importance of collaboration and really the placement of HDC as a mechanism that helps bring priorities in data, digital, strategic information to the fore, more so in terms of collaboration, in terms of technical investments, financial investments. As you are aware, there's a lot of focus since the era of SDG started has been on data. With the realization that really, if you can't measure, you are not able to tell how far you have moved. And I really want to emphasize that the HDC has really come a long way in terms of helping countries and partners collaborate, prioritize together, and work towards the same objectives in terms of really harmonizing digital investments in making data available for countries and for countries, for partners, just to help in decision making and also inform interventions that are put all over. So I think as a representative for the country constituency, really our role is to, or rather my role is really to help ensure that county priorities are really at the forefront in terms of what we do, in terms of, especially in terms of partner investments. Of course, there's a lot that can be done in this in this context or in this field, but there's need for that common investment, common goals, common way of sort of tracking progress, and that is why initiatives like the HDC, the SDG Gap, UHC 2030, and other mechanisms to take stock together are really important. And I think really the importance is really to make sure that whatever we are doing is able to have country priorities at the top, so that again we are not doing things because we have a nice way of doing it, but really we are addressing ourselves to cumulatively addressing the gaps that exist, and more so in low and middle income countries. I think this is where we have a lot of gaps in terms of availability of data. I think we all appreciate things like civil statistics on death, on registration of births and deaths. Civil registration statistics have been very weak across many LMIC countries. Again, taking stock, continuously of what you are doing, being able to say where we are in terms of all the investments that go into health and health-related sector really needs a lot of data, a lot of good quality data available and on time, and of course of good quality and communicated in the right way. And of course, many countries are struggling with some of these things. So my hope is just that we can all see this as our common and really our common goal that we are all working towards. And therefore, the HDC really helps bring this to the fore. And I think with the help of the HDC initiative, we are really targeted to ensure that this progressive, progressive movement towards this sort of collaboration across countries, across partners, and across all the initiatives that are targeting this area of work, which we are all interested in. So I think that is what I can say for now. I'll pause there and hand over back to I think Craig. Thank you very much, and wishing us fruitful deliberations today.
Thank you very much, Helen, for your opening remarks, and it's great to almost see you, blurry, but good to hear you, Helen, and thank you for joining us. I know you're extremely busy with many things. We're going to now just present a few slides, as I say. Mwenya, do you mind just putting up the first few slides, and then I'm going to hand over to Mwenya in a bit. And during these slides, what we'd like to do, just next slide, it just give you as a target audience an overview of what the HTC really is, starting with a problem statement, giving you a bit more about the background and governance, the added value, and just what we're trying to achieve with our country colleagues, and a bit about the monitoring and evaluation of how HTC is monitored and evaluated at the end. Next slide. So this is our overall problem statement, and it came about from our colleagues in Botswana, the Botswana Ministry of Health, and really emphasizes data fragmentation, which we're all aware of. And the quote is really, there are multiple data collection tools used within government and the private sector. And there's inadequate data governance, that's coordination and oversight, and sharing of information for research purposes. And there are 30 to 40 reports coming in from each facility every month. That's each health facility every month. And there are 35 different electronic data systems in use. Next slide. So our colleagues in Botswana say, because of all this fragmentation, it is a headache. It's a headache for everyone, and there's a lot of duplication of work. So our colleagues, this quotation, there is a need to have an approach that would bring everyone together so that data generated across the country in the health sector is brought to one room where it can be looked at, analysed and utilised for decision making and for improvement. And that's the underlying problem statement that really the HDC is based on. And for those that are interested, next slide, the HDC was really born in 2016 at the end of a 2015 high-level summit on measurement and accountability and results with a roadmap. There was a 5-point call to action during that meeting, really based on a lot of the underlying points made by our colleagues in Botswana. There's a call to action to increase investment on the levels and efficiency of domestic and international investments, capacity strengthening, a well-functioning population health data source, specifically civil registration, vital statistics, census and surveys, effective open facility and community data systems, and enhanced use and accountability through citizen engagement and transparent reviews linked to action. And that 5-point call to action, next slide, led to the creation of the Health Data Collaborative. And the HDC's mission is to provide a collaborative platform that leverages and aligns technical and financial resources at all levels, so all levels including national, regional, global, to country-owned strategies and plans for collecting, storing, analysing and using data to improve health outcomes, with specific focus on the SDG targets and communities that are left behind. Next slide. So you heard in the video the three main objectives of the HDC, and I'll just paraphrase them here. The first objective is really to support countries' health information systems and build the capacities of them. Second is to strengthen the alignment of partner resources, whether they be technical or financial, around the country-owned plans and priorities. And the third objective is to support the contextualization of global tools to in-country scenarios. So those are the three main objectives of the HDC. Next slide. So how do we work? Our governance mechanism is based on several layers, and we have kind of one overall layer where everyone can be an HDC member in a kind of global group that you can see there that is represented in different constituencies. And within the HDC, we have 7 different constituencies, countries at the heart of it, private sector, donors, multilateral intergovernmental, global health initiatives, civil society, and academia and technical research networks, including CDC. And those 7 different constituencies, we kind of nickname them as our tribes, the health data collaborative groups or communities. And they're represented in a stakeholder representative group, which has a call every month. And they are basically the overarching decision-making group in the HDC. We're accountable to them, and they're represented in different ways. As I said before, Mwenya and myself, although we're hosted in WHO and supported by UNICEF as well, we're the HDC Secretariat, and we provide a service to help convene, share information, and make sure things really happen as best we can. And then lastly, in the HDC governance, there are a set of working groups that I'll come on to talk about in a bit. And those working groups are what we nickname the technical engines of the HDC, moving things forward with a country level focus. Next slide. So what's the added value? The potential added value of the HDC is really alignment and decreased fragmentation, as I said before, reduced reporting burden for countries, and counting those left behind. You heard very articulately my colleague Azza talking about CRVS and why it's important as well. We talk about the missing populations that aren't even counted, for example. Health security, especially in times of pandemic, there's a more coordinated response to issues like COVID-19 and other infectious diseases, and adapting global tools with country contexts, involving and engaging communities, often those living in quasi-legal situations that don't necessarily have any voice at decision-making tables, and strengthening the link between data and digital efforts as well, and strengthening the link with our research colleagues in academia and innovators as well. So there's several different elements of added value of the Health Data Collaborative for many different constituencies. Next slide. So really at the heart of it, and you know much better than we do, this group that we're talking to just now, you all are, this is your bread and butter, data and the health statistics journey. What we're trying to promote here is that the HTC is really getting the right data to the right person at the right time, in the right place, ideally in the right format. So it's everybody's responsibility, and moving along a journey that goes from collection of data through to the use of data for use in action, whether it be policy, program interventions, or budgets, for example. And we all recognize there's a series of steps that we're all part of, from collection to use and action, and they may well involve cleaning and validation, sharing and analysis, storage and visualization and dissemination. And we're aware that those individual steps may not be linear, and in many different contexts they're certainly not linear, but they're all necessary to make sure that data is used for use and action, and that collecting and using data, quality data with integrity, is part of, from our point of view, health system strengthening. It's a core part of the health system. It depends on strong governance for coordination and setting principles and standards, and occurs at all levels. This is not just a global or national or regional level, it occurs very much at the front line as well. So it's a multiple level issue of making sure that the data and health statistic journey is a strong one. Next slide. So why do we hope from this meeting, this brown bag, we think that this is really important to help you better understand what the Health Data Collaborative is doing, because many different sectors beyond the health sector affect the determinants of health, the underlying determinants of health. And health has an impact on different sectors. So many of you aren't necessarily engaged in the health sector, but we appreciate and value any thoughts or suggestions that you might have on the Health Data Collaborative. And we're certainly looking for innovations and new ideas to strengthen data governance and input for working groups and country actions. And as we go through, we'd welcome, again, suggestions or volunteers if you want to join the Health Data Collaborative to really join us in our efforts to support and strengthen health information systems across different countries. And that this might be able to, by doing this brown bag, but also moving forward, sharing resources and supporting national statistics offices and ministries of health as well. So thank you very much. I'm going to hand over to Mwenya now, who's going to give a bit more detail on the Health Data Collaborative. Over to you, Mwenya. Thank you.
Great, thank you. Thank you, Craig. I hope you can all hear me okay. Thank you, Alex. Thank you, Helen. Thank you for the opportunity. It's great to be here. I won't fully introduce myself. I've been introduced already, but just briefly. My name is Dr. Mwenya Kasonde, and I'm here as a UNICEF consultant supporting the Health Data Collaborative Secretariat alongside my colleague Craig. So let me just start by giving you examples of the types of partners we have engaged within the HDC. Craig has told you about our different constituencies. And at the moment, we have several different partners that are within those constituencies. We've reached about 60 or so different partners, including the World Bank. You can see all the UN agencies are members of the HDC, including the WHO and UNICEF, etc. We have the donors such as NORAD, UK, FCDO, I believe now called themselves, and GIZ. We have the Rockefeller Foundation, Bloomberg. We have the Global Health Initiative, which includes Gavi, PEPFAR, the Global Fund, PHCPI, to name a few. Within research and academia, we have the University of Oslo, and they've done great work, as you know, with DHIS2, and we really value their contribution to the HDC, namely to the technical working groups. We have SUNY New York, we have the London School as well engaged. We have civil society, and of course, we have the private sector as well. So let me just quickly make a mention of the DG3 Gap, because as you know, this is a very similar mechanism in which we aim to align partners behind country-driven needs, around data and digital activities. Many of our partners are in common, and indeed many of the countries that we focus on are in common. So we're very much aligning ourselves as the HDC with our colleagues at the DG3 Gap, specifically the Data and Digital Accelerator, in order to achieve our common goals. And the focus at the moment specifically is on equity and disaggregated data. And the reason for this is because we recognize that data is one of the accelerators that has a real power to drive the other accelerators even further. If you don't know about the DG3 Gap, it's made up of a number of different accelerators, as they're called, which focus on different technical areas, namely, of course, data and digital. And we also have primary health, we have healthcare financing and others. So at the moment, the focus of our accelerator is on equity and disaggregated data in order to drive, indeed, progress in the other accelerators. The countries and governments which are being focused on across both the DG3 and the HDC are namely Nepal, Kenya, Malawi, and Uganda. And the data priorities within those countries have been identified mainly around DHIS2, CRVS, and the SCORE tool, which has recently been released by the WHO. And I'll speak a little bit more about these priorities throughout this presentation. Sorry, I hope you can still, my screen seems to have changed. I hope you're still able to see my presentation. Okay. Let me know if you've lost the presentation. My screen seems to have changed. So
we can see the slides. Thank you.
Great, fantastic. So let me go ahead and speak a little bit about the countries. So it's important for me to mention that we don't want to be a closed club at the HDC. We really want to support any country, any Ministry of Health, or indeed any other relevant entity within the country that comes to us requesting support, be it technical or financial in this area. I'll also mention here that the HTC is not a funding mechanism. We don't hoard funds or provide funds per se, but nonetheless, we aim to make use of our partners and of the pool of funds that is available at a global, regional, and at national levels in order to align ourselves behind country needs and country priorities. So at the moment, our 11 focus countries are namely Malawi, Cameroon, Kenya, Tanzania, Uganda, Botswana, and we have Zambia newly added to the list in the Africa region. And then in Southeast Asia, we have Myanmar, we have Indonesia, we have Bangladesh, and we also have Nepal. I might also mention here that for political and other reasons, we've had slightly less engagement at the moment with Myanmar, Indonesia, and Bangladesh in Southeast Asia, but nonetheless, they remain one of our focus countries, and we look forward to re-engaging with those respective governments as their needs, arise. We've also received quite a bit of interest from other countries, namely Nigeria, Benin, Rwanda, and Sri Lanka. And again, we are open to engaging with any country that might believe in the HTC modus operandi. So let me speak briefly about some of the country priorities that we've identified. So one of the first things that Craig and I did as we've been working with the HTC is to indeed involve the Ministries of Health to really establish what it was that they wanted us as partners to focus on and what they were trying to achieve within those national plans. Most of these countries have their own health sector plans. Many have specific plans relating to M&E. Malawi have a plan related to digitization of the health sector, etc. So many countries have identified already a list of priorities that they would like to focus on as a government, but we discussed with these countries what specific priorities could be pulled out of what they have identified for us to rally around as HTC partners. And just to give some very concrete examples, in Nepal, the focus has been on strengthening CRVS, specifically in 22 hospitals. They're looking at counting children who may not legally exist for service provision, again, with a focus on equity. We've also made great use of the score assessment tool in Nepal to strengthen health information systems, and also linking HTC to the CRVS working group that we have within the collaborative as well. In Malawi, the focus really is on digitization of the health information systems. The ministry has recently released, I should say, a digital health strategy which runs from 2020 to 2025. So we're very much guided by that specific strategic document in Malawi, specifically with the Ministry of Health. And again, the focus here is on strengthening DHIS2 functionality, looking at implementing a DHIS2 tracker to improve management of patient-level data. Other areas of interest for the Ministry of Health Malawi have been implementing and developing a digital roadmap specifically, and also looking around areas of interoperability and alignment amongst available data and digital tools. So to go back to the technical arms of the HTC, Craig has mentioned briefly that we do have some technical working groups that work within the Health Data Collaborative that provide much of the technical support to all of these different ministries of health. So the first working group is on epidemic intelligence, and I use this I'm mentioning this with caution because due to the recent pandemic, the two co-chairs of the working group have been, of course, so overwhelmed that they've a little bit taken a step back from the Health Data Collaborative and have been engaged, as you can imagine, with other activities that relate to epidemic intelligence. At the same time, the pandemic has, of course, brought a new desire from the HDC partners to again refocus our efforts on epidemic or public health intelligence. So we have been having much negotiation and much discussion amongst the partners to see how we could potentially revitalize some of the work that this group has been doing in the past to indeed be able to better support countries as they continue to face the current pandemic. The second working group is the most active and the biggest. I think they boast of about 200 or 300 members or so. And that's the working group on digital health and interoperability. It's co-chaired by USAID, WHO, and Open Communities. And you can imagine that it's one that indeed has gathered a lot of interest amongst not just our global level partners, but indeed our countries as well. We also have a working group on logistics management and information systems. It's a slightly smaller working group, a slightly more closed club, if I can put it that way, just because of the nature of the work that they do. You have a working group on community data, co-chaired by UNICEF and USAID, that are really releasing some fantastic tools and really doing some very interesting work. We have a recently revived working group on routine health information systems. This is something that really came out strongly from our countries. Again, the countries have the countries that we support have come to us with very specific needs and areas of concern. And one of the needs that was brought to our attention was the need to strengthen routine health information systems, especially, of course, as we are in the middle of a current ongoing public health emergency. There's also a working group on data and digital governance, and you'll all appreciate the importance of this. I won't speak too much about it. This working group was born out of the Digital Health and Interoperability Working Group. Initially, that working group had a subgroup on digital governance, but it was decided that data and digital health governance was such a cross-cutting issue that it was worth pulling it out of that specific working group and creating a working group on its own. And finally, we have a working group on civil registration and vital statistics. So to speak about the HTC milestones for 2021, we have recently released our work plan, which runs from 2020 to 2023, and specifically in 2021, what we'd like to focus on are the following issues. And these issues are really based around the objectives of the HTC, which were mentioned earlier on, the first being capacity building, the second being around alignment, and the third around contextualizing global tools. So one of our main milestones for this year, 2021, is identifying a data institute to support the two regions that we currently work in, being Africa again and Southeast Asia. We'd also like to hold some peer review mechanisms for the regions. So specifically, looking at a regional institute that can perhaps host an event within the region to see how each of the different countries that we support can learn from each other. We are looking at continuing to identify data priorities within each of the countries that we focus on, and also reviewing some of the COVID-19 best practices and some of the best practices for tracking communities and including these communities that are sometimes left behind. With regards to alignment, we are looking at reviewing partner alignment and investments in all of our focus countries. And this is an activity that we are really been pushing quite aggressively, and we're hoping to be able to implement and to bring some more finalization to that over the next few months. And again, looking at a focus, a national data institute that we can focus with within the country that will support that alignment at the country level. In regards to contextualizing global tools, again, we are hoping that all of our working groups can be very well represented from all of the different constituencies of the HTC, and also making sure that tools such as SCORE, again, the tools that are being released by the community data working group are well contextualized for local use. And then just the final milestone is around the functioning of the Secretariat. So just a quick note on monitoring and evaluation, how we aim to really monitor our progress within the Health Data Collaborative. So first of all, we'd like to have some annual progress reports that are released. We're working on 2020, and 2021, of course, will be released in due time. But importantly, we also would like to undertake an independent evaluation of the efforts of the Health Data Collaborative in 2023, which will mark halfway between the beginning of the HDC and the SDGs of 2030. And also importantly, we're relying on the SCORE tool to give us a more overarching view of health information systems and how we can make progress within the countries that we work in. I'll stop there and perhaps hand over back to you, Alex, or Craig, perhaps want to take over to guide the rest of the discussion. Thanks.
Thanks, Mwenya. Alex, do you want to facilitate? Thank you.
Yes, so it's now time for our question and answer session. So we would encourage now everybody who wants to ask a question, please either raise your hand in Teams, and when we can then give you the floor, unmuting yourself. I'm just enabling the microphones for those who want to ask a question. And if not, please write the question in the meeting chat, and we can then take the question and read it out for you. So thanks, Greg, Mwenya, and Hellen for the presentation. It was really insightful. Let me maybe start off with one question that I had listening to your presentation, and that was so you mentioned it a little bit already during your talk, but how did the COVID-19 pandemic and the changes in the situation affect your work in positive or negative ways. So you had mentioned that some countries were concentrating more on the emergency things related to the COVID-19, but I can also think that probably the COVID-19 situation has brought countries closer together and has probably improved also the collaboration within the country. So maybe you can say a couple of things on that. Over.
Hellen, I wonder whether you wanted to go first, since you're working firsthand really in the ministry and want to reflect on that. Thanks, Hellen.
Okay, thank you. Thanks for the question. Yes, certainly the COVID-19 pandemic has presented an interesting challenge. In terms of how countries work together. I think maybe one of the most important examples I can cite. There has been a lot of learnings, a lot of sharing of experiences between countries in terms of, for example, making sure that data that allows a response to COVID is available, as soon as possible, as efficiently as possible. And one of the examples I can cite is, for example, rapid assessment of facility readiness to respond to COVID, and also to continue offering essential services. This initiative was done through WHO and other global partners. I'm sure many of the participants here are aware of these COVID assessments on COVID readiness and response. As part of the ACTA, Access to COVID Tools initiative. And through this, I think there has been very targeted assessments that, for example, Kenya and the other countries in Africa are already implementing in terms of getting data very quickly and efficiently. In terms of readiness, looking at what is happening in health facilities, readiness in terms of drugs, health workers, even capacity for beds, capacity for surge in cases, and these assessments have been done initially using phone-based surveys that are have been quite efficient in terms of time and also in terms of resources. So that's one example I can cite, but there are many other collaborations that are going on, thematic teams that have regular meetings. I think the joint learning network that in which PHCPI I know facilitates has also been bringing a lot of countries together to learn on various mechanisms of sharing and having tools. Well, maybe not tools, but just learning how others are handling specific challenges that are more or less similar across countries. So I think this in itself is a good thing. As much as COVID really is not a positive thing, it has brought a lot of good lessons in terms of learning from each other, sharing, and trying to see how collaborations can be scaled up across many countries very, very quickly. So that's what I can say for that. Thank you.
Thank you so much. I see also a question in the chat by Bill Anderson. I don't know, Bill, if you feel comfortable in unmuting yourself and ask the question yourself. Otherwise, I can do it for you.
No, I'm here. Hi, I just, from the presentation, I got a very clear understanding of what you're doing at a national level. And I was just wondering to what extent the HTC itself focuses on the use of data at facility and local government level. and sort of that virtuous cycle of as data gets used at a local level, it then therefore improves the quality of the data.
Mwenya, do you want to take that one?
Sure, thank you, Bill. That's a very good question. So I'll answer that in two ways. The first thing for me to mention is that we're very much guided by the Ministries of Health. We're guided by the ultimate client. So much of what we do and what we focus on is indeed, guided by what their specific priorities are. And many ministries indeed do have a priority around enabling capacity building at subnational levels. I know Hellen in Kenya is one of those, given the devolved system that they have, with the health sector in Kenya. But of course, but also we have a specific request actually from the Ministry of Health of Nepal, again centering around that very issue around enabling subnational use of data and local use of data, provincial use of data as they call them in Nepal. So certainly, if it's something that the Ministry of Health is focusing on, it's definitely something that we also aim to respond to within the HTC. The second thing I'll briefly mention is also, again, I mentioned the community health data working group that we have the HTC, which also in itself focuses on that subnational level, empowerment. This is in contrast, for example, the Routine Health Information Systems Working Group, which is more focused on the facility level data, community data, really go much deeper, if I can put it that way, and trying to get much more capacity building at indeed that community level. Thanks.
Sorry, my computer is a little bit slow in unmuting myself, so sorry for that. Thanks for this answer as well. There was another question in the meeting chat with respect to privacy of data and how that is ensured in the working of the health data collaborative at a national level, I guess, but maybe this is also something that refers to the exchange of data between to the WHO and so on. So this question was asked by Matava Polan. So I don't know who wants to take that. So the question was on data privacy and how to ensure this.
Sure, I'll take a stab at it. I'm not sure I have the answer to it, but I can give you an overview in the last year and a half of what work has taken place. So there's been no specific focus on the Health Data Collaborative on data sharing per se, but I think the pandemic specifically has raised the profile of how member states specifically can or can't share data, and it's renewed interest on data sharing policies. So within WHO, for example, there is a data sharing policy, which is 2017. There's been a lot of interest last year. In fact, we convened working group members, which included some HTC members actually, to help advise us on how best to implement that data sharing policy and look at disseminating it and strengthening the capacity to do so. The second thing I would draw your attention to is under the auspices of UN Global Pulse, under the Secretary General's office, there was actually a jointly signed statement of data privacy and data sharing for COVID-19 signed by over 30 UN agencies. And that was coordinated by UN Global Pulse, and many of you on the call may well have been part of that process as well. But the last thing I'd like to say is that the working group that Mwenya mentioned on data and digital governance really looks at quite a few aspects of data sharing as well, and they will be part of a data governance summit, which is coming up at the end of this month and in September as well. So we're really focusing on data governance and data sharing as well. I hope that helps, Alex. I know it didn't answer the question directly, but those are kind of three thoughts that I had. Thanks.
Thanks, Greg. So again, everybody, if you have further questions, please raise your hand in Teams or write the question into the meeting chat. While we have a little bit of a shy group today, so let me ask maybe one more question myself. So you were talking also about the importance of digitalization between in the countries to make the health data collaborative work. Can you say maybe a little bit about the challenges that you are facing? Because I can imagine that within countries, especially developing countries, the level of digitalization or computerization in the health facilities in the country differs quite a lot, maybe from the capital region to more other cities, regional cities, and rural areas. So maybe you can say a little bit about those challenges that you are facing.
Helen, I wonder whether, given your experience in Kenya, whether you had any thoughts specifically.
Yeah, thanks, Yuxi and Craig. Yeah, this is one of the areas that is, of course, attracts a lot of interest across partners. It is also very, very tricky because there are many partners that have invested in digital solutions. And if I was to give an example of Kenya, and I think it also cuts across many other developing countries, you find that many partners come with solutions that are implemented in either for a disease program or for a specific geographical region in the country. These systems are very sort of independent. As you're aware, a system will have a developer, a source code, and all these things. So in many cases, you find that these systems are not interoperable. One of the requirements, for example, we have in Kenya is that the system needs to be able to share data with our national data aggregation system, the DHIS. And in many cases, you find that some systems maybe, say, for a certain disease program or implemented in a certain geographical region. For example, in Kenya, we have counties, 47 counties, sub-counties. So you might find actually someone implementing a certain county or sub-county for a certain disease, but then that data is not able to be, it doesn't get very useful in terms of scalability. So the thing is, we are not able to scale many of these investments, and they are sometimes not able to share data with our other systems. And it is also not, of course, it doesn't seem to make sense to say now let's harmonize all these systems into one, because it's very difficult, because all of them are programmed differently and all that. So that's one of the challenges that has been there, and I think it's one of the issues that maybe with the HDC can help to streamline, so that partners sit on the same table and maybe work well in the future. I think I foresee a future where it will be possible for partners maybe to invest towards a common data digitization platform that can be built on top of each other. I think we've worked with partners. I think WHO currently is helping us digitize facilities across the country using modules, so that you're able to build one, the HIV module, the pharmacy module, the lab module, and that helps a lot in terms of making sure that these cumulative gains as you build the system. But it is not an easy area, and of course there's a lot of investments that have gone into this, and it's one of the areas really that need continuous thinking together towards a common goal. Yeah, thank you.
Thanks so much, Helen. There's another question by Ismail from Esquire in the meeting chat. I don't know, Ismail, if you want to ask it yourself. If not, I can also just simply read it out. So Ismail was asking, how can countries in conflict make use of your initiative? So over to you, Craig, Hellen, Mwenya.
Sure. So if I understand the question correctly, how can countries or agencies make the best use of the HDC? Was that the question?
Sorry. The question was, how can countries in conflict make use of your initiative? So considering their special situation due to conflict.
Okay, sorry, I misheard. So Ismail is a really good question and very timely as well. So as we all know, many of the communities who are left behind live in fragile contexts, whether that be due to humanitarian situations from conflict or natural disasters, and collecting and using data in those circumstances, often communities cross borders as well. So they may not be affiliated with a certain country. So we've engaged and we're part of UNOCHA has been part of the HDC, and they have a very active working group on data sharing specifically, but other aspects. And we've tried to encourage other groups that may be working in fragile contexts, specifically ICRC, IFRC, and MSF in the civil society constituency to join the HDC as well. In terms of actually encouraging a country to join the HDC, many of our partners would like to encourage a fragile setting context joining the HDC, and various names have been suggested. So I think, Mwenya, I'm going to ask you what thoughts you have, but we very much welcome, and as Mwenya said, it's very much an open door. We welcome that, and I think there would be support by HDC partners to do so if there was a context you have in mind. Mwenya, do you have any thoughts?
Thanks. Indeed, it's a good question, and it's something that that we've discussed quite a bit, throughout the collaborative, and we still haven't, of course, found the perfect answer to it. But one of our goals as we increase our country reach is really, as mentioned by Craig, is to target more of these fragile settings and see how we can better support countries indeed that are under a fragile political or other situations. And again, I give the example of Myanmar, for example, who was quite well engaged and heavily engaged within the HTC as it started towards 2016, 2017. But recently, we've been advised by the Ministry of Health that it just wouldn't be right for them to engage too closely, obviously because of the ongoing situation there. So we really are very much guided by the country itself. If the country sees value in the HTC principles, we aim to support them as best as we can. We're really trying to use a bottom-up approach as opposed to a top-down approach. We're not trying to come into the countries to tell them what they should be doing, but we really want to be guided by the countries themselves. But it's a good question. We haven't found the perfect answer to it. We hope to engage more with fragile states and other countries of small island states. Fragile states are two of the sectors that we haven't quite been able to target, and we aim to better target in the future. Thanks.
Thank you so much, Mwenya and Craig. So thanks a lot for joining us today for this Global Network webinar on the Health Data Collaborative. Please note that the recording of today's webinar will be shared on the Global Network. So if you haven't joined yet the Global Network, please go ahead and join it. The link has been shared by Yushi in the meeting chat, and thanks everybody for joining. Thanks everybody for asking questions today, and especially a big thanks to Greg, Mwenya, and Hellen for giving this great presentation of this initiative. Thanks so much.
Thank you. Thanks, Alex.
Thank you.
Thank you.
Goodbye.